I see some of the most severely infertile men on earth, right?
Yes.
From all over. And I always listen to John. And he said, you should try this. Who wouldn't want to take a pill instead of having surgery to have a chance at being a biodad?
The best email I ever get is the baby picture. I work with the men when they're trying to get their wives pregnant. And if they succeed, then I really don't see them during the pregnancy. But about 9 to 10 months later, I get an email. It's pretty thrilling.
The paper we just published is our consecutive series, the first 30 some odd men, very severely infertile. We're talking no sperm in the ejaculate or very unreliable counts. About a third of them developed reliable ejaculated sperm in having pregnancies and babies when they didn't have anything to start with. And I said, I don't care what that number is, that's important.
Welcome, everybody, to another edition of Talk with Turek. This is a podcast about male fertility and sexual health. My name is Rob Clyde, and across from me is Dr. Paul Turek.
Hi, Rob Clyde.
Good morning. How are you?
Good morning on this hot Saturday morning.
Hot Saturday morning. Today on the show, we are going to be talking with Dr. John Amory of the University of Washington about a study that you two have published.
Great colleague.
And the study is saying that you can stimulate sperm production in severely infertile men.
Yes.
That's what we're going to be talking about today.
This is novel research starting from a conversation at a water cooler.
But before we get to the good doctor and talking about that, I had something that I wanted to bring up to you today.
How unusual, Rob Clyde.
Right. Well, look, so this is my Turek Clinic folder that I got because, so when people say this is just a doctor, this is my doctor. This guy did my vasectomy, right? And so anyway, I found this because we were going through some stuff this summer, and this is my certificate.
You have a certificate of honor for meritorious performance and bravery at the time of his vasectomy. Nobody gives you any street cred for having a vasectomy.
This is true, right? I mean, I'm the one that has touted it more than anybody. I made a podcast about it. That's me at your clinic in San Francisco when we did that.
We did
screening of the film and met. We would go back. That's 10 years ago.
Wow.
Because what I found in there was this, which was you drawing on the day. My testes, the day of my procedures.
On the Good Morning America day, right?
On Good Morning America was outside, and you said, Rob, you only have one tube.
And this is what it looks like.
And this is what it looks like. And you asked me, when you told me I had one tube, because I didn't know, how many kidneys do you have?
You didn't
And
know.
I said, I guess I don't know. I assumed I had two. But the 70% of men with one tube only have one kidney. Those aren't great odds, I would say. So then, as I was also cleaning out, I was looking through some other medical records of mine.
Jeez, Rob.
Okay. And I got a CAT scan in 2015.
That was after we met.
This is after we met.
Yeah.
And it says here, chest wall was good, normal.
Good.
Cardiovascular, but because
There's
it was
a
all
heart
about
there. You've got a lot of heart.
But when it comes to upper abdomen, it says non-visualization of the left kidney.
Wow.
And I did not know that. And so I saw that. So does that mean I don't have
Correct.
it?
You don't have a left kidney.
That's a statement?
And
that's not that they just couldn't
it's
see
the
it.
same side as your vas deferens.
Well, that's what I saw today. So this morning when I looked
put
at
it
the thing,
together.
I put it together
Mr. Sleuth.
because the truth is I don't remember which testy you did it on. But this is the other evidence. I just needed this, and it says that I didn't have a left tube.
So that means you can't go, motocross racing or you can't be on a horse all the time. If you have a kidney stone, you go straight to the ER because there's only one bean there.
Okay, so Max, before you got here, was saying, so what does that mean? And I said, the only thing I know that means is that I'm not on the list to donate kidneys.
That's right.
But I also know that I only have one, and so if I screw that one up, I'm in trouble, right?
Right. So you have kidney precautions. Just take it easy. Not a lot of contact sports.
So the non-visualization, that's like not just a tech that's saying you couldn't see it.
That's a weird term for you're missing it.
So maybe I would still want to go get a
ultrasound,
sonogram or an ultrasound.
Don't get a CAT scan. It's radiation.
No, I didn't need to. But
medical sleuthing.
I'm 90% sure now that I have one kidney, and we say it's on the right.
And it should be doing normal function, normal lifespan. And it's probably twice the size of a kidney.
Really?
Yeah, it grows. When you're missing one, the one that is left over does the job of two, and it grows bigger.
I mean, so seriously, this is me, just confirming with a doctor that maybe I have one. All right, moment of silence for my left kidney, perhaps. Okay. So you took your daughter up this weekend to college?
Nothing compared to that story.
No, it's
we
can't follow that one. But yes, go ahead.
The question is, how often do you get really close to a 19 or 20-year-old daughter? And she has a 35-year-old station wagon we talked about that she bought, and we drive it 900 miles to school in Oregon from LA, and it's just magic. It's 2 days, stay in a hotel, and to go to cool places like caverns and stuff like that.
Yeah.
And just talk every hour or so. Some conversation comes up. It's very natural, and I get to know all about her, and it just feels magical.
Pretty
so we've
great.
done it for 3 years now.
Yeah.
Maybe the last couple times. Lately, her boyfriend's taking her back, so I'm like, just been displaced, but
That's going to happen.
Dad's still in there.
That's why we figured, well, we've been doing this a year, because in the first episode or right around there, and you took your daughter up to college, and we talked about it, and it's like, man, it's going fast. Life is rolling by, right? Well, enough about my kidneys and enough about our trips. I want to get to this great information that could be a true breakthrough.
This is very exciting.
And so let's get to our guest, Dr. John Amory. John, welcome to the podcast this morning, John. Thanks for joining us.
Thank you.
We appreciate it. Dr. Amory received his undergraduate degree from Harvard University. And
I want to pause there.
Yeah.
Because almost every guest we've had on this podcast comes from Harvard, and I typically, as a Yalie, get a rash. I'm surprised that I haven't gotten a rash, but this whole podcast is Harvard.
Yeah.
What's going on?
He likes
Rob?
you. He likes you. That's Jennifer. That's our producer, Jennifer, who is lining these up. And I got to say, John, I don't know. What
No
do you have to say
hives.
to
I
that?
think I'm desensitized.
I have a lot of respect for my colleagues from Yale, especially Dr. Turek.
Some of my best friends, right?
Noted.
Yeah.
So John got his undergraduate from Harvard, his MD from the University of California, San Francisco, where he also completed his residency in internal medicine. He has also earned both a master's degree in public health and a master's degree in pharmaceutics from the University of Washington. Yeah, pedigree. He is currently a professor of medicine at the University of Washington Medical Center, where he works as an attending physician on the inpatient medicine wards and in the general internal medicine and men's health clinics. One thing to note on his bio is he lives in Seattle with his wife, Josie, who is also a physician specializing in perinatal
Poor kids.
palliative care, and they have 2 adult sons as well. But what we found out is Josie is the technical person in the family that
Bailed John out.
bailed John out as far as getting the microphones to work and such.
One of the point that we're relevant for is John and I are both past presidents of the American Society of Andrology, which is the leading scientific sperm society in probably America and probably the world. And that was probably sort of the fundamental basis for our collegial relationship.
That's good. He's also you rode crew.
Indeed.
I have a concept too, sitting in my garage, just not being used. I do enjoy it, but that's serious.
This is Rob
exercise.
in LA talking.
Yeah.
Yeah, it was a lot of fun. I had a wonderful coach, a guy named Harry Parker, who's sort of the Bear Bryant of rowing, if you know what I mean, and that was thrilling. One of my teammates won a bronze medal at the Seoul Olympics in 1988.
Wow. Yeah, I mean, Harvard crew is as good as it gets, right? Yale, Harvard, and Cambridge, and Oxford, and
That's where
The highlight of our year every year was the Harvard-Yale race, of course.
Yeah,
in
I'm sure.
New London.
Let's get into it. Tell me about
That's
you.
exciting
You guys were you at this convention or a recent convention when you guys?
John, it
hooked
was
up
in
again?
San Diego 3 years ago, maybe. John was talking about his research on isotretinoin. So I'll let John talk about that, but he was just sort of pondering what was happening and what he had found from some earlier research and publications in infertile men. John, you were trying to work on making a contraceptive, an oral pill for men with this product, with this substance, which is important for sperm production. So tell the story, John, about maybe the background of it.
Yeah.
Yeah, it's a fun story, actually. So I've been involved in male contraceptive research for about 30 years. And much of that research focused primarily on using hormones like testosterone to suppress sperm production. And that works fairly well, but not 100% of the time. So we were looking for alternative ways to sort of think about making a contraceptive. And there's also additional benefits to not using hormones when you're trying to develop a male contraceptive. And to make a long story short, this old drug was actually discovered over 60 years ago that turned out to work great as a male contraceptive, but didn't make it to market because of side effects. What we found is that drug was blocking the ability of the testis to convert vitamin A from the diet into the active form of vitamin A, something called retinoic acid. And it turns out retinoic acid is very important for making sperm. In fact, if you make an animal vitamin A or retinoic acid deficient, it'll get night blindness and male infertility. So we thought this has been sort of an underexplored avenue towards male contraception, and I've spent a large part of my energy over the last 15 years trying to develop male contraceptives based on this. At the same time, I work in the men's health clinic. I have some wonderful urologists, Tom Walsh in particular, that I work with, and I was seeing a lot of infertile men. And I'm an endocrinologist, so the infertile men that I classically see are men who have hormone problems. They're lacking certain key hormones that are required to make sperm. What's gratifying about them is we can resupply these hormones and we can reinitiate spermatogenesis in these men, and usually they'll go on to have a successful pregnancy and a live birth. The sad part of the story is that really only represents about 10%, 10 to 20% of all men with infertility. Most men with infertility, and especially the severe forms, we don't have a lot of options for them, certainly not medically. We can send them to people like Paul, who can do a testicular procedure and find sperm some of the time, but not 100% of the time. So, there is this type of male infertility that's very severe, very limited options. And so, of course, given that we were working on blocking retinoic acid as a male contraceptive, the idea popped up, maybe some of these men are actually deficient, not in their hormonal axis, but in this vitamin A retinoic acid way. And in fact, we did some measurements of retinoic acid in the testis of men with infertility, and the retinoic acid levels were lower. We found out that, wow, geez, if we can actually supplement them with retinoic acid, maybe we can boost sperm production. That was the hypothesis. And in fact, we first studied men who had low sperm counts. They weren't zero, but they were low. And several of those men increased their sperm counts dramatically with an oral form of retinoic acid called isotretinoin. Worth talking about isotretinoin for just a second. It's kind of a drug with a little bit of a stigma. So isotretinoin is a drug that I've used before to treat acne in my general medicine practice. It's a good drug. It's very effective at treating the most severe form of acne. It does have some baggage. And the biggest baggage is it was recognized in the 80s that if a pregnant woman took it, it could cause severe birth defects. So it's a teratogen. And that led to this program where the provision of isotretinoin for patients is pretty prescribed appropriately to try and prevent pregnant women from being exposed to the drug. And that's the so-called iPledge. So we went through the process of sort of becoming an iPledge certified provider to give isotretinoin to the men. Now, several of my patients and their wives, as you might imagine, have looked it up on the internet and said, isotretinoin, that's bad for pregnancy. And in fact, iPledge's motto is committed to pregnancy prevention. So there's a real irony here when we're giving it to infertile men so they can get their wives pregnant. Yeah. But we do think that giving it to the men doesn't expose the women if they're pregnant at all. In fact, we went ahead and measured isotretinoin levels in the semen of men and in the saliva, and it's basically zero. So, and there's no evidence from observational or epidemiologic studies that men who are taking isotretinoin when their female partners conceive are at any increased risk of birth defects. So we are using this drug, and Paul can tell you that some of the results, it does seem like it helps a subset of the men with infertility. I have to add one final caveat, and that is that the use of this drug for this population is not FDA approved. This is something that we've been doing what's called off-label, meaning a provider like me can prescribe it, not for its intended use, acne, but for another indication if we think it's appropriate.
Got it. Yeah. And from a layman's side, from the everyman,
which is what you are,
which is who I represent on this show, this drug was Accutane. So
that's
just
correct.
So we can tell everybody, like we've all heard of Accutane. It was what kids were using to get help with their acne. And then Paul was explaining to me before the show, once the patents were up, then other competitors came in.
Just to buttress John's stuff and elaborate a little bit, Accutane was on the market from 1982 for 27 years.
Yeah.
And it came off the market, everyone thought, because maybe the birth defects were a big deal. It came off because of pharmacological competition with copycats. So there are isotretinoin equivalents of Accutane on the market right now that are cheaper. And so they couldn't afford it. Wasn't a safety issue. It was an economic issue.
Got it. That's smart.
In that time of 27 years, there were about 7.5 million men who took it. and there's no reports of any issues with their children. Okay, in addition to John's work looking at levels. So it's very different when infertile men take it than when teenage women take it.
Right. And so now let's talk about the breakthroughs that are happening and what you're seeing.
John's got this all in his noodle in his head.
Yeah.
Right? And we're at the American Society of Andrology, maybe at a past president, something or other. And I see some of the most severely infertile men on earth, right?
Yes.
From all over. And he said, you should try this. So we had a cup of coffee. We sat down outside in San Diego. I think I'd done a surf session that morning. I was very receptive.
Yep.
And I always listened to John. And because even though he's a Harvard guy, I always listen to him.
Yeah.
So
occasionally useful.
He starts talking in his casual tone. Like, we found this, like we talked about, the levels were lower. It's important for spermatogenesis. That's 100 years old. And then he gave it to men with low sperm counts, and they went up. And then he gave it to men with no sperm counts who were sterile, very severe cases. And some of them developed sperm in the semen. And I said, I don't care what that number is. That's important. And then he said, you should consider it. So we collaborated a couple years ago, and the paper we just published is our consecutive series, the first 30 some odd men who we gave it to, and found that it's true. What John was observing came true. A subset of these men, about a third, who were very severely infertile. We were talking no sperm in the ejaculate or very unreliable counts. About a third of them developed reliable ejaculated sperm, taking the pill for 3 to 6 months, that led to them going to IVF and having pregnancies and babies when they didn't have anything to start with. But the other cool thing was that no one dropped out of the study, really. So
Okay.
there are side effects with this, include chapped lips and dry skin, and it was during the summer, right? So that's impressive.
That's it, right? When we've been saying side effects,
Yeah.
we're really talking about chapped lips and dry skin.
I would say there are other potential side effects that we monitor for, in particular mood or abdominal pain, things like that. I haven't witnessed those in the men that I've treated, but we are vigilant for these things. They are listed as potential side effects.
We analyzed their blood and looked at their cholesterols, and it's all on the paper. You know, we really didn't see any differences in any of the metabolic things that are typically associated with isotretinoin. Other issues where we were able to freeze sperm in these men. They were able to go to IVF just to make sure the issue of birth defects. We looked at embryos. They were biopsied, all that stuff. And we got the usual number of normal embryos, and we have pregnancies now early on. It takes 9, 12 months, right? So we have the pregnancies and we have live births. So we're going to follow it, of course.
Sure. This is every day we're watching.
Right, because people are still concerned, but we'll track all that. And I thought was really impressive was there were men who didn't respond classically. I mean, they didn't have ejaculated sperm. And they underwent another operation to see if we could get sperm from their testicles. And that went very well.
Oh.
So even men who didn't respond with ejaculated semen may have produced enough sperm to have pockets in the testis. And then when we operated on them, we had at least a 75% chance of finding sperm, which was very impressive. And I didn't know this until it got reviewed, but everyone was also impressed that the time of the surgery, the operation time, was halved.
Yeah, these are numbers that are important to say to everybody, right, John? I mean, it's not just it works or it doesn't work. Paul's saying, okay, well, for ejaculate, that's the ideal, so that all I have to do is ejaculate. You're getting the sperm, you're freezing it, IVF. You're saying, but even if not, we feel like it's making more sperm that's not getting in the ejaculate that's down in there. And that's what you do is you map, and then you go in and you find them. And you're saying
that was easier.
That's easier to find them because there's just more.
And it was more successful, and it went faster, which is better for the patient. So if you can take a 3-hour operation and when you rifle through a testicle and make it 35 minutes or 45 minutes, that's impressive. And so that was data that the reviewer said to us, whoa, let's focus on this for a minute. So we crunched that data and put it in the paper too, because that's clinically important.
Really impressive, guys. Really impressive. When anytime you say rifle through a testicle, I get a little nervous. I mean, it's just a casual water cooler conversation, but the right guy to talk to from your angle, John.
Yeah.
So when you had the first initial, what if? Tell us about the journey.
Yeah, it's that pivot you made in thought, like, okay, we can block it and maybe get when did you think the opposite?
Oh, great question. I remember the boys were about 5 because I was at their swimming lesson, and I pulled some old papers.
Because that's what you do when your son's swimming. You bring scientific papers by the
Just a few
poolside. See, that's Harvard, okay?
So when the teratogenicity, when the birth defects from isotretinoin were sort of first identified, this is the late 70s, early 80s, a few researchers around the world said, well, hey, this is teratogenic for women. What happens to sperm counts when we give it to men? So there were a few publications from the 80s where they followed sperm counts over the 6-month course of isotretinoin or Accutane treatment. What do you think happened to their sperm counts? Mm-hmm. They doubled.
Oh, wow. So we're talking about young, healthy guys with acne, and they're like community controls, and you're giving them. Wow.
Definitely. So that's when I was like, I had no idea. And, those researchers, basically the conclusion of their studies was the drug's teratogenic in women, doesn't have any negative effect in men. But they weren't thinking like an infertility doctor who's like, maybe we could use this to increase sperm counts in infertile men.
Because it was in the late 70s. They were just
one
figuring
swimming
it out.
event, that one.
Yeah, and Wayne was about 5, so that would have been 17 years ago.
Wow.
Wow.
Yeah, no, it's exciting. I mean, honestly, in the current events of the world right now, the research and development is under attack by a lot of people. I think people need to hear that guys like John are at swim practice. And they, seriously, because if I would have had that thought or somebody else would have, just read that article clearly, or just another doctor, but you are the one that reads it and says, wait, I actually could research this. You have a program now through the Turek Clinic. So how is this working for people? And I want to say this too, because no man wants to hear surgery on their balls. They don't want to hear it. And you guys are saying today, no, it's sperm in the ejaculate. So
one of the unique outcomes of the paper is that the research, we used our outcome not as successfully getting sperm with testicular sperm retrieval procedures, which can be invasive.
yes.
Our outcome was the first ever, which said we're looking at reliable, motile, ejaculated sperm that could be used for technology without a procedure. So no one has ever used that endpoint reliably in the public. So that's a different one, and I think that matters.
Babies have been born, John. Is that what we're saying?
I was going to say the best email I ever get is the baby picture. So, I mean, because I work with the men when they're trying to get their wives pregnant. And if they succeed, then I really don't see them during the pregnancy. But about 9 to 10 months later, I get an email. It's pretty thrilling.
That's like science. That's going from a thought process. He was measuring levels of vitamin A, the retinoic acid in the testis, to a pregnancy. I mean, that is translational medicine at its best. I mean, who wouldn't want to take a pill instead of having surgery to have a chance at being a biodynamic?
Yeah. So what we're doing now is trying to figure out who are the men who are most likely to benefit, because unfortunately it's only a third of men right now, roughly.
Okay.
And so the questions I'm asking are, what's going on in those other 2/3 of men?
Right.
And is there some way a priori we can identify men who are more likely to respond? Because infertility is important in terms of time. You don't want a man to take the medication for 3 to 6 months that's not going to help him. So you're exposing him to side effects, and the clock is ticking on the couple.
Yeah.
In particular, the woman's getting older. And so we want to really figure out who's going to benefit and who's not. And then what can we do to the people who aren't going to benefit? Maybe there are my dream is to identify other signals like retinoic acid that could be additive or synergistic with retinoic acid to really get those numbers even higher.
Yeah, and so that's the future. And we started a program at the Turek Clinic, which is the Isotretinoin program, because it's complicated to prescribe. So even though the issues that the FDA, et cetera, noted with women in pregnancy don't occur in men, it's still a scheduled drug for men. So it is like testosterone or opiates. It's highly regulated. It's prescribed monthly. You have to have consent and an iPledge number. So Molly Jessup in the practice, who wrote the paper with John and me, she's the one running that program. It's a 6-month program, and we're going to sort of take care of the details for you, because it is not that simple, and you have to be a provider and you have to sign up. So even though we don't see those issues with men, they have to abide by the rules. So So it's a formal program.
Got it. John, how does it work?
How does retinoic acid
How
improve
does it
sperm
work?
production?
Make sperm.
In a word, John.
The actual process of sperm production, or what we like to call spermatogenesis, which is a lovely word, is incredibly complicated. It starts, so boys before puberty don't make sperm, but they do have these stem cells in the testis that when puberty occurs can be stimulated. And so how retinoic acid plays a role in that stimulation process. In fact, it's the first step. It's the step that takes the stem cell to start to differentiate into a sperm. And that process takes 72 days, which is why we have to treat people for 3 to 6 months to see results. Unfortunately, we can't speed it up. It's an incredibly complicated process. But retinoic acid is one of the signals that takes the stem cell, the earliest cell, and starts it on its maturation journey to eventually become a sperm. Now, I told you about the 1/3, 2/3 thing. It seems like the retinoic acid is more helpful for men who do have those stem cells or other forms of sperm, what we call germ cells, in the testis. So one of the things about Paul's paper that's notable, the numbers are small, but it does seem like men who have evidence of these early forms of germ cells that have stopped maturing, a condition sometimes called maturation arrest, are much more likely to respond to this than men without any evidence, histologic or microscopic evidence of stem cells. And that makes sense because retinoic acid is really a growth factor. So it's able to work on the early stem cells, the premature germ cells. I'm not able to make germ cells. So that is, I think, where we are in terms of this technology. Does that answer your question?
Totally does.
Yeah, I think it's a great observation of the early data, which is that if you don't have the seeds, it's not going to create the seed for you, which is the spermatogenesis stem cell. And in our series of men, we use mapping as the way to figure that out. And if the global look of the testis has no early germ cells in it, we had 4 men in that series. None of them responded.
You mentioned mapping. How does mapping work in the process?
Yeah, so finding the aspiration mapping is something I developed around 25 years ago that gives you the geography of the testis. And we talked about the germ cells that become sperm. There's a sequence of about 12 or 13 stages. Mapping will tell you what stages are present and what stages aren't. And because it's global, it tells you about the whole testicle. So the classic way to figure out what's going on in a testicle to understand whether they're candidates for isotretinoin would be a biopsy. And a biopsy gives you similar information, but in one spot. But we know that in these men who are serially fertile, they can have pockets and biopsies can miss it. And I think John came to me once and said, we have men which are totally cell only, no germ cells on a biopsy, and we've seen a response to isotretinoin. And I said, that's impressive because it doesn't really fit in. But probably that man has pockets somewhere else that's making sperm. And so mapping is a better way to figure that out. So I think in addition to finding sperm, if mapping is done and there's no sperm, we can learn archivally about what's going on in that testicle and say, well, you didn't have sperm, but you might be a great candidate for isotretinoin. I think it's the best way to figure that out. Mapping is the best way because microdissection doesn't give you that information. It tells you if you have sperm or not. It's a big procedure, but if you don't have sperm, you don't know much else. So mapping is going to be very crucial to figure out candidacy for isotretinoin response.
Yeah, it's funny because, John, you said 3 to 6 months, and you're like, well, unfortunately, we have to give it at least 3 months to see the results. Okay, for the layman, 3 to 6 months. I get that that time's ticking, and so, but that doesn't sound like that long to me. If it's surgery or wait 3 months to 6 months, that doesn't sound too long for me. And 30% sounds like a huge number to me. I mean, from 0.
I wish it were higher.
Yeah,
I know. John's from Harvard, yeah.
Yeah, we reach for a higher level. Right. Well, that's
I
good.
mean, the thing about experts like John is you're never satisfied with what you have.
Sure.
And I love that.
So what does the future of this therapy look like?
I think it's going to be given judiciously to the correct patients. I would like to see them screened for the patterns in the testis that are more likely to respond right now. And then, John may work on other substances or other combinations or formulas to figure out who could respond. And then I think we just continue to collaborate
There are some really brilliant cell biologists and developmental biologists working around the world to try and address that man with the absent stem cell situation. So this is what's sometimes called Sertoli cell only or germ cell aplasia on a biopsy. These are men, and when you do look in the testis, you don't see any stem cells. But people have made incredible strides with trying to develop stem cells. So I think that will be probably how we're treating infertility in 50 years. Is a man, if he has no stem cells, will be able to take other cells, maybe from the bone marrow, maybe from other sources, and kind of convert them into sperm stem cells, maybe transplant them into the testis or even in the test tube trying to develop sperm. And I think retinoic acid will be part of that. When, people do in vitro studies with sort of trying to develop sperms, they use retinoic acid, they use testosterone, they use the growth factors that we know about. So this is a really interesting area, and I think I'm excited to see what our colleagues come up with.
Yeah, I mean, it's fundamental. Retinoic acid is fundamental to sperm production. And John has shown is realistically manipulatable this is your foot's in the door.
Yeah.
Here, scientifically.
Sure. And again, when you're using an off-label product like this, is there a future on label that is specific to sperm production, or do you partner with a person that's currently making it? Is it refined, the therapies and things that you're doing from a reproductive endocrinologist versus a doctor that's prescribing for acne? Is there a difference in the future?
I would love to see that, actually. I would love to see a company get interested in this space for several reasons. It gives it some legitimacy. B, they would fund a larger sort of trial that was more rigorous and sort of scientifically, well done. And you can actually take a drug and get it approved by the FDA for a new indication if you do the necessary studies. And so the investment from a drug company would actually be a lot less than a classic drug, which they have to take through animal testing and all these other things. So that would be great. And they do get, I believe, 3-year period of exclusivity if they do that. And that's happened for a few drugs. So there is, I think that's the Hatch-Waxman Act, if I'm not mistaken.
Of course, John.
Of course, the Harvard.
I'm not a legal expert.
So, John, what's next for you? What are you working on right now? Does it to make this better, or like you said, finding the stem cells and working with the other 60%?
Paul mentioned the Andrology Society, which is a great society. It's sort of half doctors, half PhDs. And I've just in the last year connected with a PhD colleague, actually from UCSD, and he is an expert in molecular biology of sperm production. His name is Miles Wilkinson, and he's looking at the semen of men to see if we can find RNA that will tell us which populations of cells are actually in the testis. So this is a non-invasive test looking at the semen of men with 0 sperm, but turns out that there's RNA there that give you information about the cell populations in the testis.
So basically, it's a liquid biopsy of the testis using semen.
Yes. He calls it a molecular semen analysis. And that's kind of what it is. So RNA is nice because DNA, of course, is the same in all the cells, but the RNA differs. And so it gives you like an RNA signature. And so you see a very different signature in someone who has stem cells and maturing cells than you would in someone who had none of those cells. So I think that will help us potentially non-invasively identify people who are likely to respond. And it also can give us insights into what other avenues we could pursue to try and stimulate sperm production.
Paul, what about you? How does this mature at the clinic, and what are you going to do about it?
One of the things is we don't even know the dose that men should take, right? The doses we use are the classic doses for acne, but it could, dose response curve, it could work better with more, it could work better or maybe less, you have less side effects. So at the clinical level, you can dial it up or dial it down to try to get a better response. I think the first thing is to figure out, which populations are responding and let them know, because if you're Sertoli only, it may not be worth, I don't know if it's worth it yet. 4 men, no response, it's still a chance, right? Sure. And I don't want to hang carrots in front of patients who have little opportunity. So if it's 1%, I wouldn't say it's going to work for you. I would say chances are it won't. It's not 0, and let them use the number to decide. Sure. Because they do tend to grab onto any percentage So you have to be careful.
Yeah, our audience are people in the field, but it's also people that are trying to get pregnant. Right, Mr. Everyman. I was once in this group, John, so they're clamoring for any piece of positivity, right? And that's why we've actually been careful through this podcast to not make claims that are just, we don't want people grabbing old Accutane and popping it and thinking they're going to get their wife pregnant, right? So we are being careful. But at the same time, it matters to people like me that don't get this. And I think the conversation around the NIH and that people need to understand that, man, 17 years is not too long to wait to find answers that are going to bring you kids. And thanks to you guys for thinking outside the box, for having a cup of coffee, and the relationships matter. The fact that you were presidents of the Sperm Society sounds like quite the
you don't talk about it much
elitism of that. Like, we are the ones.
If you show up at the meeting and say, "What society you guys in?" You don't want to know.
Yeah,
you don't want to know.
Well, I'll tell you a funny joke. So andrology is not a word that people use very much, but it's really the male counterpart to gynecology.
Right.
But I had a doctor colleague who asked me once, andrology, what is that? The study of androids?
Well, we were going to work AI into this podcast however we could. So
we have to.
Androids that make it might be the future.
And it's really interesting because when this gets presented to urologists, a lot of them, they make their money and living and are focused on procedures. This is a paper that is focusing on no procedures for couples, for men. And I presented it to gynecologists, and they're very excited because it's new business for IVF, right? This is people who are never candidates are now candidates to be biodads. So it's an interesting reaction we're getting. I'm a surgeon who's publishing a paper saying that surgery may not be the way to go. And that, I think, is where the education comes in, because you have to take care of the patient, not your practice, right?
Thank you for that, too. Again, I actually read that earlier and came to that conclusion before you all got here when I was doing my research. Like, wait, Paul makes, he makes a living doing surgery, and you're saying this is going to save you from doing the surgery.
Right. So it's not good for the practice.
Right. But it's not, but it's good because your practice stands for patient
Care.
First.
We're all about care. Right?
Your bedside manner is significant.
But it's about care for infertile couples. It's a bigger picture. Maybe that's the Ivy League education. I'm not sure.
Sure.
But we're all about the future, and we want the best opportunity for care, the least invasive.
John, any last minute words to the people listening today?
Thank you for having me. And Rob, I want to thank you for kind of bringing it back to the patient and the man in the clinic with his wife. That's really important. My wife and I struggled with infertility for a while, and I can really relate to how that feels. Absolutely. That is really a hard place to be. And especially for the men, I think the women have way more evolved than us men, and they get support from colleagues or they know someone. Men don't have that. They, in general, won't talk about this.
Yeah.
Because it's, who's the celebrity face of male infertility?
True.
Right? No one. Have you noticed on talk shows, if a couple talks about infertility and she says my tubes, my cycles, my eggs, it's her. If they just say our infertility vaguely, it's probably him.
Yeah.
Because there's a stigma for men to talk about it. It's so entwined with manliness. I really, really empathize with these men. And it's a privilege to be able to try and help them.
Well, bring your friends and colleagues to the conversation. We're having it right here on Talk With Turek.
Right on.
We are available on all podcast platforms like Apple and Amazon, and we're on YouTube. And so we're a bit missional with this, and that is we're trying to get the attention of the men and the women in their lives to focus on male fertility health and sexual health. John, Amory, thank you so much for joining us on the show today.
John, it's been a pleasure for the last 17 years.
Let's do 17 more, Paul.
You betcha.
Paul, that's 10th show in the books.
Yeah.
I'll talk to you in a month.
Okay.
See ya.
Bye now.
Thanks for joining the Talk with Turek podcast. Today's show was executive produced by Rob Clyde and Jennifer Harris. DP engineered and edited by Drew Unser. Thanks to Avery Clyde, Shen Heckel, Max Flora, and Jonathan Raju. Talk with Turek is produced and recorded in Los Angeles, California, in association with Hey Babe Media. Subscribe to our show wherever you listen to podcasts and watch us on YouTube. For more information or to book an appointment, whether in person or virtual, visit Dr. Turek online at theturekclinic.com or call 1-888-TUREK-MD, Turekmd. Don't miss our next episode as we delve deeper into men's fertility and sexual health on Talk with Turek. And be sure to follow us on Instagram and Facebook at Talk with Turek for updates and more content.